and get going. All right, lovely. Welcome to tonight's lecture on embryonic development. I'm Harry, I'm a fourth year medical student at Oxford University, and I'm going to be covering this rather large topic tonight. These are the areas that I've taken from the Oxford syllabus. We're going to try and get through as much of that as we can, but I can't promise to go through absolutely everything in huge detail because we don't have all the time in the world. I will try and keep the lecture to an hour. This is the outline. I'm going to approach it in two parts. We'll start with some basic principles of embryonic development and some key ideas that I think could be useful to you for your revision. And then we'll move on to some specific systems, which you will likely need, whether you're going to be writing essays or answering short answer questions on this material. If you have any questions at any point, please do shout out and I will try and respond to those, or save them up for the end. Lovely. So I like to open with this slide, and I think it's really important when thinking about embryonic development and any sort of developmental process to try and rationalize and think about in your head what's going on at the level of individual cells within that system. Are they dividing? Are they growing? Are they differentiating into different cells? Are they signaling to each other? Are they dying? Are they producing specific signals? Are they undergoing these processes of migration and adhesion? These two in particular are really important when we think about epithelial to mesenchymal transitions, which are those really important changes when neatly organized epithelial cells unstick from each other, become mesenchymal and poorly organized, and go on long migratory journeys. So all of these ideas, all of these processes will come up at different stages in the lecture. Oh, that's a bit of a pain. I don't know what's happened then. I think that was my phone. Anyway, sorry about that. These will all come up. They're all interesting ideas, and I think do try and think about those. So let's go over some basic principles. Beginning at fertilization, which is when which happens at the fusion of the sperm and the egg to form a zygote. That zygote, that single cell, then undergoes a number of cleavage divisions, which are mitotic divisions without growth, if you like. So it's the same cytoplasm being divided into smaller cells to produce a morula or a blastula. And then that blastula undergoes a process of differentiation where we begin to see a defined inner cell mass, which is distinct from the surrounding trophoblast cells. And these different groups of cells have important fates. The inner cell mass becomes your embryo proper, whilst the trophoblasts become some really important extra embryonic tissues. You'll also see, if you look in this top corner here, this image of the blastocyst, you get this kind of zona pellucida outer layer that forms at fertilization with the granulation reaction, and it's a hard outer shell that the blastocyst must hatch out of in order to implant. So speaking of that inner cell mass that we've talked about as the group of cells that are going to give rise to the embryo proper, the first kind of differentiation event within that group of cells is differentiation into the epiblast and the hypoblast. We call that a bilaminar germ disc. And around the same time as this, we get implantation into the endometrial wall. So the blastocyst hatches from that zona pellucida and makes contact with the endometrium, and that's when that trophoblast undergoes a number of key cell changes in order to adhere to the endometrial wall and eventually form the placenta. We get two populations emerging within that trophoblast. Those are the cytotrophoblast, which lines the blastocyst, and the syncytiotrophoblast, which invades into the endometrial wall. And it does this by breaking down cell-cell adhesions and cell walls to become a syncytium, which is one very, very large cell formed from numerous smaller cells that merge, and it has many nuclei. We also see the formation here in the bottom left of this amnion. So the cavity that we already have in the blastocyst is over here. That's still there, but we get this second cavity within the inner cell mass. And what's happening to form that? Well, we're getting changes to kind of the way cells stick together, and they secrete ions into the lumen, and fluid follows ions, and that's how you get this expanding water-filled cavity within the middle of your embryo. And by the time the amnion forms and expands, the embryo is now fully implanted into the endometrium. We're getting some processes going on concomitant with the formation of a placenta, so that's kind of these lacunae forming, and contributions from the uterus and the endometrium itself. And we get this coagulation plug, which is a little cap that completes the gap where the developing embryo has implanted. So we've implanted, and we have an inner cell mass with a bilaminar germ disc. There's a very key process that has to happen now, and that is gastrulation. And I would really encourage you to have a strong understanding of gastrulation and be able to answer questions on this, because it will inevitably come up. So what do we have at gastrulation? Well, we have that epiblast sitting on top of the hypoblast, which we talked about just a moment ago. And those cells along the midline of the epiblast begin to proliferate. They migrate towards the midline, and they pile up to form this primitive streak. That's a lovely example of an epithelial to mesenchymal transition that I was talking about just earlier. So these primitive streak cells invaginate into the epiblast. They dive through the epiblast, and they enter the hypoblast beneath. First of all, the migrating epiblast cells displace hypoblast cells, and they form the endoderm. A subsequent wave of these migrating cells form a new sandwich layer in between the two layers, and that is the mesoderm. And then the remaining cells of the epiblast post-gastrulation become the ectoderm. And those are the 3 germ layers, which are ever so important when we think about mapping out the embryo, and when we think about which germ cell lines are going to give rise to all the various structures. So this is a really important event in development, and is the first major event whereby those cells of the inner cell mass commit to different lineages. What else happens around gastrulation? When we have this process of commitment, we also have patterning. Now, patterning is a really important process whereby you take a shape that has no asymmetry, no difference from one end to the other, and you apply a pattern, a difference from one end to the other. And that's obviously really important in forming a fully formed human from basically a flat disc. So what are the 3 axes that are developing at this stage? An axis is where you get patterning along a specific line, if you like. So you have the major axes that we like to think about are rostral caudal, where rostral is your head and caudal is kind of your tail. You have the dorsal ventral axis, where your ventral aspect is your tummy, and the dorsum is your back, and then you have left right. And these axes are all beginning to emerge around gastrulation. So the dorsal ventral axis is kind of cutting through the sandwich, if you like. So you have the ectoderm, which is the dorsal at the back, and the endoderm, which is ventral at the front. You have the medial lateral axis, which is from the primitive streak in the midline to the flanks, the lateral aspect. And then you also have the rostral caudal axis, which is created by this primitive node, which is an expansion of the primitive streak in the rostral area, the head area of the embryo, versus the streak, which extends caudally towards the tail, and that produces a difference and helps to map out where definitive structures are going to arise. We've kind of talked about the medial lateral axis, and in that same plane, you can also describe that as a left to right axis rather than midline to lateral. and we get a really interesting process. I'm not going to go into it in huge depth here, but this interesting process going on at that cilia, or the primitive node, I should say, the cells of which express these cilia, which rotate in such a way that they produce a flow of little vesicles and particles and fluid across towards the left-hand side of the embryo. And that is important. I just heard something beep, which sometimes means someone might be trying to get in. No worries. So you get this leftward flow, which helps to determine which side is going to become the right side and which side is going to become the left side of the embryo. And it's thought that nodal signaling, which is one of these really important signaling molecules in embryonic development that you may have come across, is expressed on the left-hand side of the embryo. And a defect in this is called a ciliopathy. This can cause some kind of minor problems. For example, Cartenge syndromes, which affect kind of the cilia in your respiratory tract and your flagella of your sperm, if you're a man. But in the most dramatic and complete sense, it can cause situs inversus totalis, which is basically, as you can see from this X-ray, if you look at the position of this gentleman's heart, it's actually on his right-hand side, which is the incorrect side. Remember, of course, that when you look at an X-ray, the left-hand side is the patient's right and the right-hand side is the patient's left. So here you can see the heart is on the wrong side, the stomach, which is this bubble here, is on the right-hand side and the wrong side, and the liver here is on the wrong side. And this is due to a problem in that kind of cilia function. If all of your organs are beautifully symmetrically flipped, it actually won't cause you much of a problem. If some things are flipped and some things aren't, then you can get issues. All right, so we have gastrulated, we have formed a trilaminar germ disc. Another important process that happens during very early development is neurulation and the formation of the neural tube. So this is again involves kind of an epithelial to mesenchymal transition, not too dissimilar to kind of the way that we saw epiblast cells piling up during gastrulation. This time, however, it is ectoderm cells, and they are and we get a thickening along the midline of the ectoderm in a region that we call the neural plate. This is these cells proliferate, they expand, and they undergo this kind of folding to form a neural tube. So I'll repeat that again. We get a neural plate forming. Those cells undergo a shape change, actually, in this case, rather than a strict migration, forming a groove in the epiblast, the ectoderm, sorry, that's a bad mistake for me to make. So they form this groove, this neural groove in the ectoderm, and then they fold and invaginate inwards to form a fully closed tube. And as we kind of implied earlier, this is an important patterning event. And this kind of supersedes the primitive node and the primitive streak in really determining the rostral caudal axis, which runs from head to your tail / toes. What structures do we get developing around the neural tube? Well, we get somites and the notochord, and these are mesodermal structures which kind of condense around the neural tube. And these are really important in developing, well, the neural tube itself will become your central nervous system, your brain, and your spinal cord. And then the somites and the notochord will form the vertebral column around your spinal cord, amongst other things. I'd advise you to look over at the right-hand side here. There's small pictures, but they show this kind of invagination of the neural groove and the complete closure to form the tube. Non-closure of that tube causes spina bifida. This is it's a disease, a condition, let's say, of varying severities from kind of spina bifida occulta, which is where the spinal cord itself is fully fused, but is fairly well fused, but there's a slight structural defect that means that the development of the vertebral column around the neural tube isn't complete. By contrast, you get meningocele and myelomeningocele, which is where that closure of the neural tube is incomplete, and you get protrusion of the meninges, or in the case of myelomeningocele, actual nerves and nervous tissue. Anencephaly is what we use to describe this problem when it happens in the head area and you get brain developmental defects. And as I'm sure has been mentioned to you before, we supplement many foods in the UK with folic acid now, and that's because in a large controlled trial, this was shown to reduce the incidence of neural tube defects. So we have gastrulated, we have neurulated, but we are still fundamentally a flat disc, and that's a bit of a problem in terms of, you know, creating a fully formed human. So the next stage that happens during development, and I describe these all into stages, but I do need you to think of them as a kind of continual process, each process overlapping the other. But next up we have embryonic folding, and we get folding in two planes, if you like. We get lateral folding, which is where the lateral flank aspects of the trilaminar disc fold forwards, and that creates our tube within a tube body plan. We also see kind of how in accommodating that folding, we get the mesoderm dividing into these two layers, the somatic layer, which stays around the outer wall of the body, if you like, and the splanchnic layer, which lines that inner tube when we get of endoderm and contributes to gut tissues. In the other plane, if you like, we get rostral caudal folding. So this is really useful to think about this in terms of kind of the flexures of the spine and the shape that the fetal spinal cord takes. It's kind of a curve, one single curve. And so that's a really important process. Why are we also interested in rostral caudal folding? Well, because it brings the heart from its cranial position. Remember, and we'll come on to this, but the heart develops at the very top of the embryo near the head, and it's this folding process that dips the heart in and into the chest. We get some other important structures being formed around this time. I'd draw your attention to the septum transversum, which is this little band of mesodermal tissue that kind of is pinched inwards with the heart, which is important and contributes to the diaphragm eventually. We'll come back to that. And also kind of, you know, the vitelline duct, which is kind of completing. So that's where we get the endoderm is folded up into that gut tube in the middle of the embryo. And with rostral caudal folding, it pinches in the middle to remain continuous with the yolk sac outside of the embryo. And then we get the cloaca near your bottom and the primitive mouth where your face will eventually form. And these are areas which initially begin at the extremes of the embryo, but kind of are brought inwards by folding, where we get endoderm and ectoderm directly opposed to one another with no mesoderm. And that's where your mouth and your anus will form. And these are some nice scanning electron micrographs to kind of show those shape changes in kind of real life 3D, if you like. The segmental body structure is a really important principle that I'd like you to think about when you're revising your developmental biology. And this is a segmental body structure simply describes repeating structures. So I was teaching on this the other day, and I invite you to think about this as kind of like the very hungry caterpillar. Now, if you think of kind of a kid's book and a little insect that someone like me would draw made up of circles that are all the same, they are your repeating segments that are identical. But over the course of development, obviously, you know, this can be a more complicated insect, and it can develop, one segment develops into the head, one a middle segment with wings, and one elongated tail segment. I wish I'd included a picture of that. I think it would have been a fun intro. But no, we're diving straight into somites because I was feeling cruel. So somites are those structures that I talked about earlier, those mesodermal condensations that flank the notochord. Not the notochord, well, they do flank the notochord, but really they flank the notochord and the neural tube. We describe the area within which they develop as the paraxial mesoderm. So we have these important divisions of the mesoderm. We have the axial mesoderm, which is the midline part that the neural tube sits in. We have the paraxial mesoderm either side that contains the somites. And then we move into the intermediate mesoderm, which is IM in this diagram. We'll talk about that later. It's relevant to the development of your kidneys. And we have the lateral plate mesoderm in the flanks. So what about these somites? As I say, they're mesodermal condensations. They emerge in kind of a progressive fashions, starting at the head area, the cranial region, and moving caudally. And initially, they are identical repeating structures with the same fundamental components. Obviously, we are not made of repeating identical segments as a fully formed human. So there has to be some patterning process taking place onto these somites to tell somites in one part of the body to form kind of chest and trunk type structures, and say those further down to form kind of the sacrum and more lumbar structures. And the group of genes that are very important in this are your HOX genes. They are homeobox transcription factors. They're really complex and you'll hear them talked about a lot. Fundamentally, what I would say is that HOX genes are expressed kind of in sequence. The sequence that they are organized on the genome actually matches the sequence in which they are expressed in the cranial to caudal axis. So as you move from the head area through the embryo towards the tail, you move through different HOX genes, as you can see here, moving from HOX4 to HOX5 to HOX6. You move through different HOX genes in sequence, and that gives each somite, or rather kind of each position within the rostral caudal axis, a unique postcode or signature, if you like, that patterns, that these are transcription factors, remember, so it programs specific fates for the structures at that level in the embryo. And that is kind of how, that is the real crux, the real mechanism of rostral caudal patterning. And we call this, and what we see is we see a segmental body structure made up of those repeating somites being regionalized, you can say, and differentiating according to its position in the embryo. So we said that the somites are fundamentally repeating structures and that repeating structure is patterned to produce slightly different fates and morphologies depending on its position in the embryo. So what are the fates? What are the tissues within the somite? So we have this part in the ventromedial area. If you look at this diagram at the bottom, that's kind of on the underside and towards the midline, and that's called the sclerotome, and that forms the bones of your spinal column, your vertebrae. Those cells of the sclerotome migrate and surround the neural tube and also the notochord, and that notochord, remember, forms the nucleus pulposus of your intervertebral discs. You also get the dermatomyotome, which is the outside, the kind of lateral and back part of the somite. We call it dorsolateral. And this forms, well, it has two components really. It has the dermatome, which forms the dermis, and the myotome, which forms kind of your peripheral skeletal muscles. So I really mean the muscles in your limbs, and you can see this process in the lower figure of myotome cells migrating into the limbs to form the muscles. Thinking in this area again, I would invite you to think about where peripheral nerves are coming from. So we've talked about the neural tube as the kind of central nervous system, the brain and the spinal cord. Where are our peripheral nerves coming from? Well, our somatic sensory nerves grow, our somatic motor nerves, sorry, I should say, are direct outgrowths from the ventral horn of the spinal cord. By contrast, the sensory nerves actually form from dorsal root ganglia, which are collections of cells, of cell bodies derived from the neural crest that sit either side of the spinal cord, and they kind of, remember from your anatomy that you get the cell body sitting outside the nervous system. You get short, I'm getting confused now. You're getting short axons that dive into the dorsal horn of the spinal column, and you get long dendrites which have your peripheral sense receptors in the ends. Don't forget as well that your nervous system has autonomic components. The sympathetic part is also derived from the neural crest, and the neural crest cells are those migrating cells from the top of the neural tube that form these ganglia all around the body. The parasympathetic part is actually similar to the motor division, is outgrowths. This time the vagus nerve growing out of the brainstem, and the splanchnic nerves growing out of the bottom of the spinal cord. And then finally you have the enteric nervous system in your gut, which is neural crest derived. So thinking for a moment about those motor nerves, those nerves that are direct outgrowths of the spinal column, and what we see here is a really important process whereby that segmental structure, the segmental structure of the somites, is translated into kind of a segmental structure of the peripheral nervous system. What on earth do I mean by that? Well, associated with each outgrowth from the neural tube, we have a somite. And we've discussed that somites, they're these repeating structures, but they are fundamentally, they are patterned to adopt specific fates for their position. So what we get is we get this a motor nerve growing out at the level of each somite, and it grows through the caudal half, that's the tail half, if you like, the bottom half of each somite. Why does it do that? Well, because the cranial half, sorry, I've misspoken there. So it grows through the cranial half, that's the top half, and that's because the caudal half, the bottom half, produces these signals, these efferents, which repel the growing nerve fibers. So what the somites are doing is they are focusing the outgrowths from the spinal cord into kind of distinct, segmentally allocated fibers, fibrous outgrowths, each allocated to one somite. But I've misspoken again there, because the nerves are actually not allocated to a single somite, but rather as the nerve fibers grow through the somite, they dissect it in two, and you get a process called resegmentalization, in fact, where actually two half somites, the bottom half of one somite and the top half of the somite next to it, kind of fuse together, and that's the unit that will give rise to a single vertebra in the spinal cord, and kind of that's how we get distinct vertebra, the bones of the spinal column, with nerve fibers growing through them and out kind of at each vertebral level. What's interesting to think about is that your somites do this cool thing where they enforce a segmental pattern onto the peripheral nervous system. They also give rise to muscle and dermis. Remember, dermis is the part of your skin that contains your sense receptors. So actually you can begin to see how nerves growing out of a single point, a single level of the spinal cord, will innervate muscle and skin, also derived at that level from those somites at that vertebral level. And that is how we see your dermatomes and myotomes established. Those are kind of the peripheral distribution of skin and muscle innervated by one spinal level. A quick reminder of the neural crest. These are those migratory cells. They delaminate, they undergo an epithelial to mesenchymal transition as they unstick from the dorsal part of the neural tube. They go on these long and complex migration pathways and give rise to lots and lots of key structures. I would flag to you those parts of the peripheral nervous system that we talked about, but also contributions to the heart and to the face and neck musculature and skeletal systems. Whew! That was quite a rush through those kind of basic principles that we wanted to talk about, and I think it will be now useful we're about halfway through, so I think it'll be useful now to go and think about some specific structures. A reminder on this slide of those divisions of the mesoderm that arise around embryonic folding. So let's think about the limb. The limbs emerge from the lateral plate mesoderm. So that's kind of your flanks, if you like, and they are buds, swellings of mesoderm. We can see the specific spinal levels they emerge at, and they are associated with specific HOX genes that act at that, and the HOX genes themselves upregulate a different set of transcription factors, in this case TBX genes, TBOX transcription factors, to induce kind of the upper limb TBX5 and the lower limb TBX4. At the point of each limb bud, we get this thickening of the ectoderm overlying the mesoderm, and that forms the apical ectodermal ridge. And that's important, A, in kind of inducing the expansion and outgrowth of the mesoderm underneath, and also as a patterning centre. So the limb bud is a really nice system for thinking about embryonic patterning. We have 3 centres, and they each produce chemical morphogens. Morphogens are, as I said, chemicals, diffusible molecules that elicit different effects on cells depending on the concentration that they are received at. So it means that you can have an area, a patterning centre, secreting these signals. They diffuse along the length of the limb bud in this case, and they induce different fates depending on kind of how far away you are from the patterning centre, and therefore how much of the signal the cells are receiving. So the apical ectodermal ridge uses FGF signals as its signal, and that helps to pattern the proximal to distal axis. That's kind of your fingertips to your shoulder, if you think about the upper limb. We also get the zone of polarizing activity, which I always found a little bit confusing, but I think of it now as kind of in your armpit. Not very nice to think about, but this produces this morphogen SHH, sonic hedgehog, great name, and it patterns the cranial to caudal or anterior posterior axis. This is a bit of a complex one to think about, but I think of it as it's positioned in your armpit, and then if you kind of extend your arm out, it patterns from your little finger to your thumb. A low amount of SSH, sonic hedgehog, i.e. on the opposite side of the hand to the zone of polarizing activity, induces the formation of the thumb. And I remember this by saying that hedgehogs don't have thumbs. And finally, patterning kind of the dorsal ventral axis, which is kind of your palm to the back of your hand, is done by Wnt signals that are released by the dorsal ectoderm. And this is, again, my little diagram to help you think about those axes and to help you kind of picture what that means in a fully formed person. The ZPA is a bit confusing, and the reason it takes slightly different names, anterior, posterior, cranial, caudal, it's kind of to do with how the limbs rotate during development, but I wouldn't worry about it too much, just kind of learn it. I'm sure in your lectures you'll have seen all types of horrific pictures like this, and it really, the limb and the limb bud is a powerful way of showing some of the techniques we can use in developmental biology to show how these patterning centers work. And basically this diagram shows, you know, what happens if you remove one of the patterning centers, you duplicate it, and you see kind of get a bit of an idea of how patterning plays out. Having said that, we get some other examples not from the lab that kind of give us an insight into how patterning happens. And a real powerful example of this is the thalidomide babies. So you'll have learnt about this, but thalidomide was used as an antiemetic drug to help treat women with morning sickness. Little did they know that it somehow disrupted limb development, perhaps through altered blood supply to the limb, but definitely disrupting FGF signals from that apical ectodermal ridge, and therefore preventing the outgrowth of the limbs and their proper patterning. Another condition associated with FGF signaling is achondroplasia or dwarfism, and it's not as dramatic as this. The apical ectodermal ridge is not removed as it is in this experimental model, but if you get abnormal FGF signaling, then that prevents the proper outgrowth of the limb bud, and that gives you achondroplasia, which is that type of dwarfism with kind of a normal sized trunk and head, but short limbs. A quick reminder of the 3 types of ossification that happen in the development of limbs. I'd draw your attention to endochondral ossification, which is the process by which your long bones form. And that's where you get a cartilage model, which is subsequently invaded by blood and osteoblasts within the shaft, the primary ossification center, and also at the head, the secondary ossification center. We then get this process of kind of epiphyseal growth, which is where long bones don't fully fuse until, after puberty, and that allows long bones to continue to grow in postnatal life. And this is a lovely diagram, but it reminds you of the primary and secondary ossification centers of the long bone, separated by this cartilage plate, the epiphyseal plate, and you get this ongoing expansion and ossification of the cartilage within that plate to allow you to grow. And this is driven by insulin-like growth factor 1, IGF-1, which is closely related to growth hormone, but is actually the hormone that produces most of your postnatal growth. It's an interesting example. You can see, I haven't got pictures included, but if you have IGF-1 excess before your plates fuse, then you have really, really long bones and you are a giant. If you get IGF-1 mutation or excess during adulthood, say, once your plates have fused, then it gives you acromegaly, which is this really distinctive, coarse, large hands. Remember the histology of this as well. This is a lovely diagram that I would advise that you have a look at. All right, let's go for let's hit off another system, the heart. The heart is a really important developmental system to know, and based on kind of my experience in the Oxford system, it's probably the one you're most likely to be questioned on. So a reminder that you get these cardiac fields, which are mesodermal structures. They're in the lateral plate mesoderm, and they arise during gastrulation with the cells that migrate and end up in that position are induced to adopt these cardiac fates. There's this process called vasculogenesis there, where the cells within the cardiac field coalesce and form these endocardial tubes, and they are in the lateral aspect of the embryo, so you get 2 of these. With embryonic folding, those 2 endocardial tubes are brought close together and they fuse by zippering up, and that forms the primary heart tube. And a reminder, once again, and I'm sure you'll remember this from your lectures, this is happening in the cranial-most region of the embryo. It's kind of the very top above your brain at this point. You have the heart field developing in the lateral plate mesoderm. So you have this heart tube. It's formed by the fusion of the 2 endocardial tubes with embryonic folding. And this is what is going to begin to undergo morphogenesis and form the adult heart. How does it do that? Well, it becomes detached from its surrounding structures, except for the inflow and outflow tract, and it begins to grow. And that, if you have growth within a confined space, you are going to have looping and folding. And in the case of the heart, it folds towards the right-hand side. I'd like to draw your attention, do I have it on here? There's this second heart field, which is of increasing interest in the scientific field. It kind of just sits alongside that primary heart field that we talked about. And it doesn't contribute to the initial endocardial tubes, but cells originating just adjacent to these are important in allowing the elongation of the heart tube at this later stage, and therefore contribute to many important structures in the heart. So you've got this heart tube and it begins to loop towards the right-hand side. It's interesting to think about what tissues are contained within this heart tube. So we have on the very outside, it gets encased in mesoderm, a different type of mesoderm. This is the splanchnic mesoderm that lines the visceral organs. And the splanchnic mesoderm also contributes to this interesting structure called the cardiac jelly. Now, this is like, as it says, it's a jelly that forms between kind of the initial heart tube, the endocardium, and this layer of splanchnic mesoderm around it, which will eventually become the myocardium and the contractile apparatus. It's initially fairly acellular, but it becomes invaded by cells from the endocardium and also neural crest cells, which we have met before. And this has a really important role in kind of forming, first we call them cushions, and then we call them septa. And it's very important for septating the atrioventricular canal, so splitting off the atria from the ventricles, and also septating the outflow tract. So initially you have one common outflow tract for left and right sides of the heart, and it needs these endocardial cushions which divide that tube. They also kind of spiral due to the hemodynamic forces of blood leaving the heart, and that separates a common outflow tract into the pulmonary trunk and the aorta. That septum secundum isn't meant to be there, but there's my slides, my animation, oh bless them. So you get the septum primum. So this is about septating the left and the right sides of the heart from each other, whereas those cushions were more about septating the atria from the ventricles. So you get the septum primum, which descends from the roof of the atria, and it doesn't completely fuse, and then you get this foramen primum. Why is it important that we maintain a foramen? Well, it allows blood flow from the right side of the heart into the left side of the heart, which is important because we are bypassing the lungs at this stage. The lungs are closed and not well perfused because you are not breathing until you are born. Huge news. So initially that septum primum does completely fuse with the atrioventricular septum below it, but by this stage we get a process called apoptosis, which means that there is still that perforation, that hole in the septum to allow that blood flow from right to left. We then get the septum secundum, which is the second atrial septum, if you like. It descends from the roof of the atrium just to the right of the septum primum. This one is thick, it is muscular, it never completely fuses at the bottom, and that leaves this foramen ovale. And remember, if you look at the anatomy of the heart, of the adult heart, you get the fossa ovale within the right atrial wall, which is kind of the remnant of this structure. So what happens when septation goes wrong? Well, when cardiac development really goes wrong, we could get all sorts of congenital heart defects. The most famous amongst them really is teratology of Fallot. This is kind of an eponymous syndrome. It comprises 4 characterized defects, which are kind of a ventricular septum defect, so the ventricles aren't fully separated from each other, pulmonary stenosis, narrowing of the pulmonary trunk. You get the aorta overrides that defect in the ventricular septum, so you kind of get blood mixing at all times from both sides of the heart, made possible through that defect in the ventricular septum. And you also get right ventricular hypertrophy, spelt very funnily in this diagram, but that is due to the increased amount of work that the right ventricle has to do to overcome that pulmonary stenosis. You are born with teratology of Fallot, and babies present really classically. It's when they're crying, you know, increased oxygen demand for all those tears, and you get kind of the baby goes a bit blue, cyanotic, and has symptoms of hypoxia, fainting and seizure and things, and we call that a TET spell. Okay, so we've kind of touched on this, but we do have changes to the circulation that happen at birth. So remember, in the prenatal term circulation, the lungs are completely bypassed. There is very limited blood flow going to the lungs because they are not being ventilated. So we have the foramen ovale to shunt blood from the left to the right atria. And we also have the ductus arteriosus, which takes kind of any blood that does end up in the pulmonary trunk and allows it to escape into the aorta. Also remember that we have the umbilical vein and the umbilical arteries to perfuse, to allow delivery of blood to the placenta for gas exchange and nutrient delivery. And we also get this ductus venosus, which is a mechanism by which blood returning from the umbilicus can bypass the liver. We don't need the liver to do all of its usual processing, so it can bypass the liver and be delivered straight to the heart, because remember, this is oxygenated blood. So we want to get it back to the heart and around the body. Now, after birth, after circulation is not something we want to think about. So after birth, with your first breath, your lungs open. There is a significant drop in peripheral resistance in the pulmonary circulation, and suddenly the lungs begin to be perfused. That causes a few instantaneous changes, one of which is the closure of the foramen ovale, which, you know, as the pressure in the right atrium suddenly decreases because of as the pressure in the left atrium suddenly increases because you've got that the venous return from the lungs, then that causes a pressure change, and it causes that the flap, that foramen ovale, to snap shut and block off that communication. Similarly, the ductus arteriosus also degrades and persists as this remnant ligament, and that is due to the changes in PO2. It's kind of a HIF, hypoxia-inducible factor type signaling pathway, but that stops the shunting of blood from the pulmonary trunk into the aorta. We also have some changes to these areas further down, and that ductus venosus changes, it degrades, but it takes a few days rather than the other changes, which are more instant, and it's to do with prostaglandin signaling, and that is kind of how we establish the adult circulation, the double circulation, where the heart and lungs are treated separately. Patent ductus arteriosus is typically a problem. It causes shunting of systemic aortic blood into the pulmonary circulation. It means that the heart has to work harder and you get pulmonary hypertension, which in turn can lead to right-sided heart failure. However, there are some cases where this abnormality is actually quite useful. If you have teratology of Fallot, as I described earlier, and you have an overriding aorta and a great big hole in your interventricular septum, then actually a persistent ductus arteriosus can be life-saving because it overcomes that pulmonary stenosis that we talked about before and allows some of the blood in the aorta to leave the heart, and it allows some of that blood in the aorta to be diverted into the pulmonary system, and actually it can keep you alive and asymptomatic for a little bit longer. This is also the case in the diagram here, which is a case of transposition of the great vessels. If you were looking at this diagram and thinking it looked a bit dodgy, then you are absolutely right. In health, the right ventricle does not drain into the aorta. But in a situation like this as well, where those great vessels are transposed, a patent ductus arteriosus is life-saving because it allows a small amount of oxygenated blood to get to the right place and just about keep you alive. Lovely, so that's the heart. That's a really important model system for development and for you to learn for your exams. Sticking with mesodermal structures, let's think about the urogenital system. Now we're moving into the intermediate mesoderm now. We've dealt with the structures of the lateral plate mesoderm. We're moving into that intermediate part, which you'll remember from the picture I showed you earlier. Now you develop three primitive nephric systems, which is quite cool. You only need one. So within that intermediate mesoderm, you get a structure called the mesonephric duct. And then sequentially, you get these structures that I'm about to talk about budding off that duct. The first of this is the pronephros, which is the earliest structure. It's evolutionarily the most primitive, and it's basically like some basic tubules branching off the mesonephric duct. And these quite rapidly degenerate. You then get the mesonephros, which is more complex, and it's kind of some more developed tubules branching off the mesonephric duct. And these are actually functional, so they produce a small amount of urine which you excrete through the cloaca and which actually contributes to amniotic fluid. And it's quite a gross thing, but actually by absorbing water, amniotic fluid through the mouth, the filtering effect of these primitive mesonephros, and then peeing it out, the baby, the developing embryo, actually modulates and adapts its own amniotic fluid. It changes the composition to keep itself happy, basically. And as I've said, some of these actually persist for quite a while to perform this function. And then the third primitive nephric system to form is the metanephros. And actually, this is kind of in the caudal area, the furthest down. It's the latest to develop, and this is the one that gives rise to the definitive kidneys. So what do we have? We have a uteric bud, which is kind of a little outpouching of the mesonephric duct, and that forms the collecting systems of the definitive kidney. That bud grows into an area of metanephric mesenchyme, which is kind of an area of mesoderm just immediately adjacent to the mesonephric duct. And that forms initially this structure called the nephric vesicle, and actually eventually gives rise to kind of the mature morphology of kind of the glomerulus, with your Bowman's capsule, your proximal tubules, your loop of Henle, your distal tubules merging into the collecting duct and the collecting system, which is derived from that uteric bud. And it's a really interesting case study for development, actually, because you get reciprocal cell-cell signaling between the uteric bud on one side and that metanephric mesenchyme on the other side, such that each is required for the other half, if you like, to develop properly and form a functioning kidney. And in this red box, the red boxes, by the way, throughout the slides are kind of extra bits for interest, for extra points in essays or whatever. And it just gives you an idea of how it's reciprocal signals between the mesonephric mesenchyme in pink and the bud in purple that mediate this development. So you have BDNF signaling, which induces RET signaling in the bud, which induces the outgrowth. You get Wnt signaling from the bud to induce the formation of nephrons in the surrounding mesenchyme. And then you get WT1, Wilms tumor gene 1, which is really important in regulating the branching process that happens to this bud. So the uteric bud starts as a single bud, but branches out to form kind of the tree of your collecting system. And Wilms tumor gene is an interesting one because it's mutated in diseases causing polycystic kidney and potentially progressing into nasty renal tumours in young children. Remember that the kidneys, so the kidneys start, your metanephros is in a very caudal region, and actually these need to migrate up to your flanks. And if this doesn't happen, then you get kind of then you might get a kidney stuck down in your pelvis, a pelvic kidney, or if they get trapped by one of the vessels growing out of the aorta, then you can get a horseshoe kidney. That's if kind of the two metanephros never fully divide from each other. It's a bit of a weird one. I never fully understood it, but basically the metanephri fuse, create this horseshoe shape that cannot elevate. And actually interesting, think about pelvic kidneys. If you have a kidney transplant, they'll actually transplant it down in the kind of in your tummy, similar to where that pelvic kidney would be located, just as an aside. And then here's a reminder of the rest of the urinary system. So the mesonephric duct forms the ureters that drain the collecting system of the kidney. They also form the trigone of the bladder, which is that triangle shape that has the openings of the ureters at the two poles that comes down to the opening of the urethra at the bottom. The remainder of the bladder and also the urethra is formed by this urogenital sinus. That's an endoderm structure, actually, so it's a little outpouching at the bottom of the gut. It leads into the allantois, which is kind of that part of the It's a strange little pouch that comes off the gut tube in the kind of cloacal region, and it contributes to the bladder. And then the mesoderm surrounding these structures forms the smooth muscle of the bladder wall, for example, the detrusor muscle. We also have the reproductive and the genital systems, which kind of develop hand in hand with the kidneys and the nephric system. So a little reminder that you have your germ cells that are ironically some of the earliest cells to differentiate during your development, but they form outside of your body. They form in the yolk sac wall, and they go on this long journey through through into your trunk, into your body via the dorsal mesentery, and they end up in the intermediate mesoderm. They arrive in that region around the mesonephros. Remember that middle kidney, the ones that kind of work for a bit, but then decline. And it induces that part of the intermediate mesoderm to form the genital ridge. And with the arrival of these germ cells, the cells in the genital ridge are induced to form kind of the support cells of the gonads. So those are this kind of cells within your testes and your ovaries that support your germ cells, your sperm and your eggs to develop when the time is right. We also see kind of a second duct arising in the intermediate mesoderm. This is the paramesonephric duct, it can sometimes be called, but the Mullerian duct is what it's often known as. So we have these primitive gonads developing where the germ cells have migrated into the mesonephric region of the intermediate mesoderm, have formed the genital ridge. They've induced the surrounding cells to become gonadal support cells. And now there's a really important process that decides whether this is going to go down a male developmental pathway or a female developmental pathway. So remember, if you males have XY as their chromosomes, their sex chromosomes, and the Y chromosome contains the SRY gene, so that's the sex determining region of Y, and this produces SRY protein, which induces those support cells around the germ cells to become Sertoli cells. Sertoli cells produce anti-Mullerian hormone, which causes those Mullerian ducts, those second set of ducts that we talk about, to degenerate. I'll bring that up in a sec. Those Sertoli cells induce the next set of mesenchymal cells, if you like. There's a kind of cascade of induction here to form Leydig cells. That's the other major cell type in your definite testes. The Leydig cells produce testosterone, and that promotes kind of the survival of the Wolffian duct or the mesonephric duct to form kind of the structures of the male reproductive tract. So here's just a little reminder of that. It's all about the SRY gene inducing Sertoli cells, which in turn induces Leydig cells to produce testosterone and cause the mesonephric duct to persist and form the male structures. Sertoli cells also produce AMH, anti-Mullerian hormone, which kind of turns off female development, if you like. It's sometimes described as kind of female development is the default pathway, and in the presence of the SRY gene, we deviate from that. In reality, female development is much more complex than that. But you know, it's quite useful to think about kind of female as one pathway, and in the presence of SRY, you get a different pathway. So what happens in females? Well, the somatic support cells become follicular cells in the absence of the SRY protein. Follicular cells induce thecal cells, so they're the two cell types of the ovary. And in the absence of testosterone and anti-Mullerian hormone, the Mullerian ducts persist and become the fallopian tubes and the uterus, and the Wolffian ducts or the mesonephric ducts degenerate, and you don't get the development of those male structures. There's also kind of dimorphism at the external genitalia, and similar to the development of the gonads, we start with this kind of indifferent phase where you can't tell which way it's going, and then the two diverge. And the divergence is kind of attributed a lot to those Leydig cells, which produce testosterone and push all the structures that you see here towards a male development. So as you can see, common structures in the indifferent phase give different structures during development, depending on the presence of testosterone or not. So the genital tubule forms either the glands of the penis or the clitoris. You've got the urogenital sinus, which kind of fuses along the bottom of the penis and I think contributes to part of the penile urethra, whereas in the female it forms kind of the vestibule of the vagina. Finally, so you get the genital folds, which forms the labia minora within the female external genitalia. And then finally, you get the genital swelling, which contributes to the scrotum in the male and the labia majora in the female. There's a bit of movement and things around these areas as well. So remember that the gonads are forming up in the mesonephric region, so it's kind of up towards the flanks, which isn't where they should be. So the testes undergo a really long descent. They're pulled by this ligament called the gubernaculum, and that pulls them through the abdominal wall and into the testes. 1 in 25 boys are born with non-descended testes. And when you get to your clinical school and you see a young lad presenting kind of 8, 9, 10, well, pre-puberty really, presenting with what you think is appendicitis, an important check that you have to do is actually examine their external genitals and check that they have 2 testes within their scrotum, just by palpation, because actually the pain in your right iliac fossa that we can often associate with appendicitis can also be caused by a non-descended testes that has become strangulated. As for females, the ovaries actually do descend a bit, and that is guided by the gubernaculum, but not to the same degree. The gubernaculum becomes 2 really important structures in the female pelvis. These are the round ligament of the uterus and the round ligament of the ovary. It's also important to remember that the kind of entire female reproductive system becomes kind of folded or enveloped within this broad ligament, which folds up from the base of the peritoneum. Behind the uterus, you get this deep folding in of the broad ligament to form the recto-uterine pouch, or the pouch of Douglas. And when you do surgery in females, it's important to remember that that pouch of Douglas is the kind of inferior, it goes a long way down. And if you have any sort of fluid or pus or collection within the abdomen, then you have to look right down in the pouch of Douglas and clear that out to make sure that you've got rid of it all. This is just a really quick, think about some other pelvic anatomy. So around the insertion of the gubernaculum in the bottom of the pelvis, you get this processus vaginalis, which is again a kind of outpouching of the wall at the bottom of the abdomen there. This expands over the course of development and pushes through the 3 layers of the abdomen, the transversalis fascia, the internal and external obliques. And these are the 3 layers of the inguinal canal, which is of clinical importance when we think of inguinal hernias and femoral hernias. And a femoral hernia is differentiated from an inguinal hernia based on whether it comes through the deep ring and how reducible it is when you apply pressure to that deep ring. Whew. Right, that is an hour. I am going to continue. I'm sorry that we're overrunning a bit, but hopefully it should only be another 10 minutes. We're on to the endoderm. I like the endoderm. My current clinical placement is in hepatobiliary and pancreatic surgery, so this is relevant to me. I'll just pause for a second. So, thinking back to embryonic folding, we remember that the endoderm folds inwards. It's the ventral aspect of the trilaminar germ disc, and with lateral folding of the embryo, it forms kind of a complete circle, the gut tube within the embryo, and that is what we call the tube within a tube body plan. And that endoderm, the gut tube, forms the mucosa, the epithelium lining of the gut from your mouth to your anus. We also talked about the differentiation of the mesoderm into that splanchnic layer and the kind of layer around the outside. the somatic layer, and the splanchnic mesoderm, that part immediately opposed to the gut tube, forms kind of the smooth muscle structures associated with the gut. The gut tube, it's not completely free floating, and it's suspended from the back of your peritoneal cavity by a dorsal mesentery, which is kind of a stalk of mesoderm to connect those two, the splanchnic and the somatic mesoderm. And we, when we, if we think about the small bowel and things like that, the organs free flowing within the abdomen, then they are suspended from the wall, the back wall, by this dorsal mesentery. And also certain structures, for example, parts of the large colon, the duodenum and the pancreas, are actually retroperitoneal, which means that this dorsal mesentery fuses with the back wall, so giving these organs the appearance that they are behind the posterior parieter of the abdominal cavity. Remember as well, so those structures, the gut endoderm structures that kind of fuse with the back wall, we call them secondary retroperitoneal, whereas structures that just develop behind the that peritoneum, because that's where the intermediate mesoderm is, I'm talking about your kidneys, they are just primary retroperitoneal organs. So this is a messy slide. I'm sorry it's a bit busy, but remember that the gut tube, when we're thinking about the formation of the different parts of the gut, we divide it into the foregut, the midgut and the hindgut. These are the three embryonic parts of the gut tube, and they are classified based on their blood supply. So the celiac trunk supplies the foregut, the SMA, the superior mesenteric artery, the midgut, and the inferior mesenteric artery, the hindgut. And you can see from the slides the structures that are sitting within those broad classifications. So let's think about some of the morphogenesis. How do we go from a tube that's just kind of like a pipe to a really complex and folded gastrointestinal tract? Well, first of all, kind of in the foregut area, we get the ballooning out of the stomach. That happens because the dorsal wall grows faster than the ventral wall, and that's what gives you the lesser and greater curvatures of the stomach. It's simply a matter of differential growth. And then there is also a rotation process to bring the stomach to kind of sit on where we expect it to be, up on the left-hand side. I'm saying the left-hand side, I'm suddenly doubting myself because it's quite late on a Thursday for me. But yes, your stomach is on your left-hand side, take it from me. And it has that kind of characteristic shape, which then goes into the C shape of the duodenum. And that's all due to kind of this 90-degree rotation of the stomach, as you can see photographed. Now the midgut, we're thinking about the second part of the duodenum and the small bowel, and then the ascending and first part of the transverse colon. This is a long bit of bowel, and it grows and grows and grows during development, and actually initially most of it grows and grows and grows outside the body. It's herniated through and out into the yolk sac, which is kind of what allows it to grow so much and to get so long and to fold and form kind of that shape that we're used to. So what we kind of get is we get this structure. The guts have herniated out into the yolk sac. They're attached by that superior mesenteric artery, that key structure that defines the midgut in the center. And then kind of as the abdomen gets bigger and can accommodate those organs, the guts, the small bowel is retracted into the abdominal wall by the SMA. They rotate 90 degrees counterclockwise, as if you're looking at it from the front. I had a ferocious tutor here in Oxford who would insist on that point. She wouldn't mind me saying that, I don't think. So yes, we get this turning by 90 degrees and this retraction into the abdominal cavity, which gives kind of the shapes and the folds of the small bowel. And then moving into the hindgut, this is the second half of the transverse colon, the descending colon, and into the sigmoid colon and the rectum. And I wanted to draw your attention here to those organs that become secondarily retroperitoneal. So that means that the dorsal mesentery that suspends them out into the abdominal cavity kind of retracts, and they fuse into the posterior parietum and kind of appear behind the back wall of the abdominal cavity. What structures are we talking about? We're talking about the ascending and the descending colon. We are also talking about the duodenum, which is obviously foregut, and the pancreas, which is in the foregut area as well. At the back end, if you like, the gut tube is continuous with the cloaca. That's an endodermal structure. Initially, it's not septated, so you have kind of urogenital and bowel emptying into the same vestibule, an anatomical arrangement that is actually preserved in birds. They eventually septate to form, either the urethra or the vestibule of the vagina and the anus. But initially they are one opening. It's also interesting to note that kind of where you get the endoderm plugging into the ectoderm derived cloaca, you get this pectinate line, which is actually an important anatomical landmark if you're ever examining the rectum on a sigmoidoscope or by digital rectal exam. The pectinate line is actually important because it determines determines pain. So if it's outside the pectinate line, typically a pathology there will be much more tender and painful than one inside the pectinate line because of the different development and the different innervation of those areas. That was a busy slide. I said I was on hepatobiliary and pancreatic surgery this week, so these are the slides that I'm really interested in the moment. And within the area of the foregut, we get these really important outpouchings, these diverticuli, which form key structures. So the hepatic diverticulum forms the liver. The diverticulum itself gives rise to hepatocytes, the bile tracts and ducts via these kind of intermediate cells called hepatoblasts. The outgrowing diverticulum grows into the septum transversum. Remember, that was that impinching of mesoderm that is brought into the middle of the body cavity by embryonic folding, rostrocaudal folding to be precise. And it grows into the anterior and inferior aspect of the septum transversum, which is mesoderm, and that mesoderm gives rise to some of the supporting cells around the hepatocytes and the bile ducts. Another little diverticulum is the cystic diverticulum. They're all on the ventral aspect of the duodenum, but this one is a bit caudal to the hepatic one, and this branches out into the ventral mesentery, which is that mesoderm kind of ventral rather than dorsal to the tube, and this gives the gallbladder and your cystic duct. Finally, the pancreas actually develops from two buds, the dorsal and the ventral pancreatic bugs. That's a good typo. Buds, yeah. These are outpouchings of the duodenum again. Both buds kind of undergo this branching pattern and development, and the buds themselves give rise to all the cell types in the pancreas. So the acinar cells that produce endozymes as kind of the exocrine function of the pancreas, and the ducts which are associated with those, and then also the endocrine cells, the islet cells, of which there are numerous different types, notably alpha and beta cells. You get this process whereby the ventral bud migrates around the duodenum to fuse with the dorsal bud. That is kind of where the C shape of the pancreatic head comes from. So the dorsal duct gives rise to kind of the body and the tail of the pancreas, and then the dorsal part, the ventral pancreatic bud, forms the head and the uncinate process. If you get a problem with this migration, then you get a defect called an annular pancreas. Pancreas works fine, it's having a whale of a time, but your duodenum is strangulated, and you will get symptoms of obstructive bowel quite early on in development. Just a quick reminder about that septum transversum that we spoke about a second ago. In the inferior part and the anterior part, it contributes to some of the supporting cells of the liver. It also forms the central tendon of the diaphragm, which is the fibrous part of the diaphragm. Remember, the diaphragm is that big muscle that separates the thoracic cavity and the abdominal cavity. We get that dorsal mesentery, which connects the gut tube to kind of the back wall of the abdomen. So that stays and it suspends the intraperitoneal viscera. But with the turning of the stomach, and I've got a picture of this coming up, it actually forms this big kind of hanging pouch in front of the bowel, which we call the greater omentum. Finally, you have the ventral mesentery, which is kind of dissected into two by the developing liver as it grows up. So that initially was connecting kind of the foregut to the anterior abdominal wall. So it's divided in two by this large growing liver, and the anterior part connects the liver to the anterior body wall, and we call that the falciform ligament, and it's an important landmark in surgery. And the posterior part forms a pouching of tissue between the liver and the stomach, called the lesser omentum. And this is just a reminder of that. You have the greater omentum, which is a folding of the dorsal mesentery suspended from the greater curvature of the stomach, and then you get the lesser omentum, which suspends between the liver and the stomach. I'm going to mention hepatobiliary and pancreatic surgery again, because I observed the removal of a gallbladder today, and with that you do a lot of dissection of that lesser omentum to get your access and make sure that you safely remove the gallbladder. We are nearly there, I promise. 5 minutes, 5 minutes. One last endodermal structure, which you should not forget about because they're jolly important. The respiratory diverticulum is an outpouching in the ventral area of the foregut. Whoa, where have we seen this sort of developmental pattern before? So yes, all these structures, the liver, the biliary tree, the pancreas and the lungs, and actually other exocrine organs, kind of your salivary glands and things like that, all have this similar developmental pattern. In the case of the lungs, you get this outpouching, we call it the respiratory diverticulum. It initially kind of elongates along the ventral aspect of the foregut, and that's what forms the trachea and the larynx. It's obviously really important that that septum between the trachea, between this kind of the trachea and the larynx and the esophagus behind is maintained, and there are many problems if you get a fistula, a hole between those, a communication during development, then you can aspirate your stomach contents into your lungs, which is bad. You can't breathe, it's bad. It's probably quite painful as well. Around day 26, the respiratory diverticulum undergoes its first bifurcation or bifurcation. That's splitting in two, and those are your two lung buds. And then you get a further 16 rounds of branching to develop the respiratory tree. And as I've kind of alluded to, this is a familiar pattern of development, and we call it branching morphogenesis. Now, where have we seen this? We've seen it in the kidney, that uteric bud and the way it interacts with the mesonephric mesoderm to kind of branch and form the collecting system. I've seen it in the liver and the way it interacts with kind of mesodermal tissues of the septum transversum, etc., etc. We've seen it with the pancreas, we've seen it with the biliary tree, and now we're seeing it with the lungs. And it's kind of all these organs where there's kind of branching ductal systems, you get like the respiratory tree or the biliary tree, etc., etc. Exocrine glands as well, your salivary glands, etc., which we won't cover here. They are typically formed by this process of branching morphogenesis, and it's a highly conserved process in these different organs. You can see on the right-hand panel it comparing the lung and the kidney, and it's where this single bud kind of undergoes repeated bifurcations, splitting in two to form this, progressively smaller lumens, massive surface area, interconnected duct system. And as I said, it's these reciprocal interactions between the bud itself, in the context of many of the organs we've just talked about. It's that endodermal bud, the surrounding tissue, mesenchymal tissue just being not endothelial, disorganized, but often it's mesodermal tissue because that's the splanchnic mesoderm that immediately surrounds the endodermal gut tube. And it's reciprocal interactions between those that direct the process of branching morphogenesis and also contribute to kind of the surrounding supporting tissues of the organ in question. And we've seen that for those organs that we've just talked about. This is really interesting. If you get a point later in your careers, I doubt you're going to need it a lot for preclinical embryonic development, but branching morphogenesis, it's quite fab. It's very interesting. I kind of alluded to these structural deficits of lung development on the left-hand side. You know, if you get a abnormal fistula or a blind-ended esophagus here, all going to cause problems. You're not going to be able to eat. You're going to aspirate your stomach contents. You're going to be poorly. Important to identify. Probably a bit more common than this is a condition called newborn respiratory distress syndrome. Now, if you've been revising your lung physiology recently, you'll remember that you have kind of an oily surfactant that lines your alveoli, reduces the surface tension in those air sacs to allow them to expand easily when you inspire. Now, if you don't get the production of that surfactant, then your lungs won't open on your first breath. And I really emphasize the point that when your alveoli are completely closed, there's a lot of surface tension there, and you really need the surfactant to open them up when you take that first breath, allow you to start breathing by yourself after you've been born, and also induce all those cardiovascular changes that we visited earlier. So where babies don't produce this surfactant, often because they're very premature, they experience acute respiratory distress. It can be very severe, but it can also be very simply treated by giving them a little oral spray of this kind of sympathetic surfactant to allow the alveoli to open. Oh, I'd forgotten that I'd included this. These are really included for your own notes. I'm not going to go into it in great detail. A reminder that you get these brachial arch structures in the head and neck structure, in the head and neck area. And remember, you know, the head and neck is really interesting in development because you have the heart developing in the cranial-most region, then you get embryonic folding, it moves down into the chest, and you get that kind of this intermediate area where the face and neck structures are going to develop. So you get 5 arches, helpfully numbered 1, 2, 3, 4, and 6, because the 5th arch just appears for a bit and then disappears. What a pain. I hate it when people do that. And these, again, similar to the somites, it's a segmental repeated structure. Each brachial arch has the same components. It has a cranial nerve, it has a muscular component, a skeletal component, and a vascular component. And they each form a definitive cranial nerve, some bones, some muscle, and also there's a blood vessel in there as well. All of those structures are actually formed by the neural crest, which is why we say that the neural crest is so important for the development of the head and face, the neck as well, face and skeleton. There's a neater way of saying that, the head and neck musculoskeletal system, let's say. So remember, repeating structures. You also get the clefts kind of on the outside, which form important structures like the external auditory meatus, the kind of ear canal, or you can actually get those like brachial cysts that persist into adulthood, where you get kind of fluid development, like fluid-filled cysts on the side of your neck, corresponding with the remnant, the pharyngeal or brachial clefts. And yeah, so lots of important structures develop from these. Remember, what are the key bits to remember? I'm not going to go through this whole graph in huge detail because it's a lot, but really just to remember that each brachial arch has a cartilaginous component, a muscular component, an artery component, a nerve component, and then there's also the associated pouches and folds that are going to form interesting structures internally and externally. A good set of flashcards, a lovely handmade revision table like this one that I've made for you is what you need for this area. That's it. I promise that's it. That's been a very whistle-stop tour of lots of areas of development. I hope that's been useful. If you have any questions, please shout them out now, pop them in the chat, drop me an email. Also, please fill out the feedback form. It's really interesting and useful for me. And you can also download a copy of these slides, which I hope will be useful for your revision. All righty.